proud PFRH alumna, and she's also a member of the 120 under 40. So this is a little bit of a homecoming for her. But for those of you who don't know her already, she is also recognized as a real thought leader in family planning measurement, and someone who I think successfully straddles kind of the measurement academic field and the policy implementation field. So, you know, she's published over 20 peer-reviewed articles in such minor rags as The Lancet and the WHO Bulletin. But at the same time, during her time at DHS, she was also really instrumental in advocating for and the inclusion of demand satisfied in the SDGs. And so sort of embedding family planning in that really important set of goals, sort of politically as well as measurement wise. More recently, she has served as a Brookings Fellow in 2020, working on Capitol Hill, responding to the COVID crisis. But she has since then returned to USAID, and now she is the deputy of the health division for USAID's Bureau for Africa. So she's currently leading a team of public health professionals who are working to improve health outcomes kind of writ large across the continent. But today, she has come back to us to talk about family planning measurement, which I was just expressing it's near and dear to my heart, and I'm really excited about this talk. And I think I'm probably not the only measurement nerd who is really looking forward to hearing her. So welcome, Madeleine, and we are looking forward to hearing you talk about rethinking unmet need.
Thank you. Thank you, Elizabeth, for the warm introduction, and thank you all for inviting me, for having me. I am really honored and excited to be here. Next slide. Thank you, JT, for doing the slides for me as well. Okay, so the invitation that I got from the Gates Institute was to come and talk about rethinking unmet need for family planning, which is a pretty narrow topic in the scheme of things, but it's a surprisingly broad ask. So today I wanted to talk about three big things, and I hope I'm not going to bore you with things that you already know, recognizing that there's probably a lot of other measurement nerds like Elizabeth and myself here. So first, what is unmet need? Second, I want to explore common criticisms of unmet need. And third, we'll talk about new measurement directions, and I'll be sharing some thoughts based on a commentary that I recently wrote that was published in Global Health Science and Practice. I hope that you'll participate in the chat by raising your hand to contribute or typing in the chat to contribute, and we'll have some time at the end of the presentation for, I hope, a more robust discussion. Next slide. So I have 4 goals for this webinar. The first is that you confidently understand unmet need, including its strengths and limitations. The second is that you agree with me, or that you more deeply understand and articulate why you don't agree, that unmet need, while imperfect, is useful, that current family planning measures do not preclude new measures, which should be developed and used, and that new measures should address various aspects of family planning related demands and desires, contraceptive use and non-use. Third, I hope that you feel empowered to participate, not just in this webinar, but in new and ongoing research and debate about the direction of the family planning field, including family planning measurement. And fourth, that we, and I mean the broad we, work together to envision and enact family planning measurement that better reflects individual level needs and demands. And I hope that this webinar can contribute just a small piece to that collaboration and conversation. Next slide. Okay, so let's get into it. Next slide. We know that unmet need is a concept that is frequently described by family planning advocates. Here's an example from Women Deliver describing the benefits of investing in family planning. Next slide. And we know that unmet need is a concept that's frequently used by program managers and researchers. Here are just a couple of examples. On the left, you'll see UNFPA's Vision 2030. UNFPA is a major funder of family planning programs around the world, and it includes ending unmet need as a major goal of its 3-pronged sexual reproductive health and reproductive rights vision. In my opinion, ending unmet need is an odd framing since we'll never end unmet need, but UNFPA didn't ask for my opinion. Moving on to the right-hand side, this is a screenshot of an entire issue that Studies in Family Planning devoted to unmet need back in 2014. And of course, there are loads of research on unmet need that's been published in the years before this special issue and in the years after. Next slide. But what is unmet need? Next slide. Okay, so here's an example of audience participation. How would you explain unmet need for family planning to a friend or a parent or your friend's parent? And if you are kind enough to oblige, you could add a comment in the chat or raise your hand and speak.
Giving folks a second to type it in.
Okay, no takers. This won't be your last opportunity. Next slide. So this is how I would explain unmet need to my parents or my friends' parents. It is an estimate of the percentage of women of reproductive age who do not want to become pregnant and are not using contraception. I might also say that it's an estimate of women at increased risk of unintended pregnancy, or even that it's a crude estimate of women not effectively reached by family planning programs. I've also heard it described as the gap between contraceptive behaviors and fertility desires. Next slide. Here are just a few examples of how unmet need is often presented in social media and traditional media. These are a few years old, but I still see these types of missives elsewhere. So ACOG tweeted, more than 225 million women around the world still lack access to modern contraceptives. And in Gender Health, Where's the Family Planning campaign asked, can you believe 225 million women still lack access? And Reuters reported the Family Planning 2020 initiative aimed to extend family planning services to 120 million women who want but cannot get reliable access to contraception. So I cringe a little bit reading these. What do you all think maybe works or doesn't work in these missives? And again, you could raise your hand or write in the chat.
It talks about women who lack access to modern contraception, but not without reference to how many people actually want them or need them.
Yes, that's a really, that is also why I cringe. It's basically saying that it's taking an estimate of unmet need and it is applying the reason for that estimate, or the reason. Yes, good point, Christina. She also says that it's not inclusive of people outside of the gender binary. Now, unmet need is only measured among women, so that will be another piece as to why you'll often see it as referred to women rather than folks outside the gender binary. But unmet need, while it's very much related to access, is not necessarily a measure of a lack of access. Moving along to the next slide. Thank you all for chiming in. It makes me feel like I'm not speaking into the void, which sometimes I feel like in the space of webinars and the computer. Yes, denominators matter, but they are hard to incorporate into flashy statements. Okay, so this is how unmet need is defined by those who measure it. So according to the Demographic and Health Surveys Program, or the DHS, unmet need is defined as women of reproductive age who are fecund and sexually active, are not using any method of contraception, and report either not wanting any more children or wanting to delay the birth of their next child by 2 or more years. The calculation includes pregnant or postpartum amenorrheic women who had an unintended or unwanted pregnancy or birth and were not using contraception at the time, And it also assumes that married and in-union women are sexually active and that in-fecund women have no unmet need. Next slide. So you may have noticed that DHS defines unmet need as women who are not using any method of contraception. And you may have asked, not using any method or any modern method? Next slide. So it depends. It depends on who's doing the calculation. Various groups, including Guttmacher, Family Planning 2020, now FP 2030, and the Sustainable Development Goals focus on modern use rather than all use. All use it includes traditional and modern use. According to Guttmacher's Adding It Up report, as of 2019, more than half of 1.6 billion women of reproductive age living in low and middle income countries want to avoid a pregnancy. Among the 923 million women who do not want to become pregnant, about 3/4 use modern contraceptives and 1/4 do not. This last group is considered to have an unmet need for modern contraception. That is, they want to avoid pregnancy, but are either using a traditional method or are using no contraceptive method at all. Next slide. So differences in unmet need measures or measurement, who's doing the calculation, can create huge differentials in estimates of unmet need. This is a chart from a paper published nearly a decade ago, which shows how numerator denominator decisions can produce major variations in unmet need estimates. So Alkema and colleagues focused on women who are married or in union, whereas Derek and Singh analyzed all women irrespective of marital status. And you can see that unmet need estimates are higher for all women, which is what you'd expect. There are more women in that category. The second difference is how traditional method users are treated. The assumption that traditional method users have an unmet need increases the number of women with an unmet need from 134 to 196 million for married women, and from 153 to 222 million for all women. Now, these data are old. These are from 2012. But the point is, the way that it's calculated matters. But regardless of the calculation used, the number of women who are categorized as having unmet need are huge. This is an area, I think in particular, this debate about modern method versus traditional method and what to include, that's a really important debate that our field needs to continue to be having. And I think it's an area that I'd love to hear your feedback on, maybe in discussion in a little bit. If you want to get it going a little bit in the chat, feel free. In the meantime, moving on to the next slide. Now I want to describe a little bit more about how unmet need is measured. So I'll ask a question, which I think is an easy one, and you have a big hint on the screen. What data sources are used for unmet need estimation? You could add an answer in the chat. DHS, PMA, And what are DHS and PMA? I don't mean what the acronyms stand for. Population-based household surveys. Yes. So we measure unmet need through population-based household surveys like DHS and PMA and mixed. On the left-hand side here, you'll see trends in unmet need among in-union women in Ethiopia, Malawi, and Rwanda from DHS. And on the right, you'll see trends in unmet need among all women in Rajasthan state, India from PMA. Next slide. Okay, and now here's another thing for the chat. How many survey questions do you think it takes to classify unmet need status? 1 question, 5 questions, 8 questions, 15 questions? What do you think? Christina says C. D, C. I appreciate y'all making these guesses. Nobody so far has guessed 1, so that's I'm gonna say you're right for not guessing 1. All right, next slide. 15 questions. takes 15 questions. Next slide. So those of you who guessed D, good job. So if it takes 15 questions, it's clearly a complex indicator. And this is a simplified indicator. Prior to 2012, unmet need was inconsistently calculated across DHS and other international surveys, including the reproductive health surveys and the mix. Levels of unmet need were not comparable across countries over time, making trend analyses impossible. And the 2012 revision of unmet needs simplified the calculation and allowed for a comparability across survey platforms. Next slide. For the heck of it, I've included the unmet need questions and filters that DHS uses in this slide deck. It's three slides worth. We're not going to really spend time on it. I just thought I'd show you. Next slide. And next slide. And next slide. So this is how these questions are used to classify unmet need among currently married and in-union women of reproductive age. So if you take a look at this flow chart, I think a few different things might stand out to you. For me, if you look at the far left, so we go, the first question among currently married women on this decision tree is whether they're using or not using contraception. On the far left, we see that no contraceptive users are classified as having unmet need. The second thing that stands out for me is that the unmet need includes recent and current unmet need. That is, it includes pregnant and postpartum women. Those are in the middle light blue column, who were not using contraception at the time they became pregnant and became pregnant with an unintended pregnancy. And then if we look to the orange columns, we see that the infecund category is a bit of a mixture of researcher interpolation and self-report. And ultimately, it's complicated. Now, I see Professor Becker has asked which of the 15 questions are most problematic in terms of validity or women's ability to answer changing rapidly over time. One of the biggest challenges is fertility intentions. We can get back to that in a little bit, but fertility intentions are generally framed in DHS as very sort of almost dichotomous. You either want within the next 2 years, or you don't want any more children, or you don't want children within the next 2 years. And fertility intentions themselves are quite fluid among individuals, and there's ambivalence and there's degrees of acceptability. And I'd say that's one of many different challenging factors that we'll get into. Thanks for the good question. Next slide. So as Sarah Bradley and team wrote in their 2012 paper describing the revision process, unmet need is an extremely complex indicator that is difficult to fully understand and even more difficult to calculate. Next slide. This is just one of my favorite TV characters of all time, Lucille Bluth, reflecting on complexity. Next slide. So moving along, if unmet need is so complex to measure and understand, why do we use it? And to answer this question, I think we need to start with a little bit of family planning history. Next slide. So the unmet need concept found its genesis in the 1960s as the knowledge, attitudes, and practices gap, or the CAP gap. And at that time, a major interest of demographers and folks working on population policy was understanding the extent to which unintended fertility and correspondingly the amount of unsatisfied demand for fertility regulation there was within the population. So like, how many unintended pregnancies were there, and how many people would be had unsatisfied demand for fertility regulation? Researchers implementing CAP surveys recognize that there is a gap in women's reported desire to space or limit births in their contraceptive practice. And then in the early 70s, Friedman and Coombs, drawing on the social psychology literature, began to estimate need. And they called the gap between need for family planning and its use discrepant behavior. Meanwhile, the World Fertility Surveys began collecting pertinent information for generating CAP gap estimates, but this type of estimation was viewed as secondary to the goal of providing sound estimates for fertility and mortality and these vital rates. So none of the 40 comparative studies produced by the World Fertility Surveys examined the relationship between fertility preferences and contraceptive use. Then in 1978, Charlie Westhoff, using WFS data, published his analysis, which coined the term unmet need. And he identified the target audience for this indicator as developing world countries that wish to curb excessive rates of population growth. Just a few years later, the DHS program became the vehicle for measuring and refining unmet need. And as Bradley and Casterline note in their fantastic 2014 paper on the history of unmet need, quote, the DHS program's investment in measuring unmet need for contraception, the care taken in developing intricate algorithms in their application in numerous country and comparative reports, is indicative of the increasing importance that the population and reproductive health field has attached to unmet need and related concepts. They go on to write, quote, because unmet need joins together contraceptive behavior and fertility preferences, the concept represents a marked shift and emphasis toward a focus on meeting individual families' reproductive intentions and away from the national program goals to curb excessive rates of population growth. So even though unmet needs started from this space of, Charlie Westhoff and before of like population policies, it came over time to be seen as a bridge between recognizing individual preferences and ways in which programming could meet those preferences. Unmet need took on increased prominence and importance as a result of the 1994 International Conference on Population and Development, ICPD. It suited the needs and interests of those who were supporting women's reproductive rights. They viewed unmet need as an indicator of the violation of those rights. And it also suited the needs and interests of those concerned with the impacts of population growth, because analyses showed that by meeting unmet need, you would ultimately see decreases in fertility rates. So the ICPD program of action gave real big prominence to unmet need, explicitly mentioning unmet need for family planning as a core rationale for population programs. And this was the real tangible shift, population, public policies, moving away from targets and focusing instead on needs. Next slide. So beyond history, unmet need is an important concept for many purposes. I've shared 6 reasons here, from monitoring progress to advocacy to serving as a conceptual bridge, informing programming and resource planning, and to its relevance to health outcomes. Unmet need is used and useful for myriad reasons. It's very possible that I have left something off this list. If you can think of other reasons, please, raise your hand or suggest it in the chat. Next slide. I also realized that I'd be remiss not to show the correlation between unmet need and contraceptive prevalence in this presentation. So here's a scatter plot I made yesterday using some DHS data from 300 surveys across 87 countries. Unmet need is on the y-axis, contraceptive prevalence is on the x-axis, and in general, what you see is that unmet need is high where contraceptive prevalence is low. But you'll also see that it's got this sort of inverse U curve. And generally, that's because as new norms about family planning and family size start to take hold, demand for family planning can outpace the availability and use of contraceptives, and thus unmet need for family planning can remain stable or even increase. Then as more women use contraception and family planning information and services expand to meet demand, unmet need for family planning begins to decline. And this again is what generally accounts for this sort of shape in the data that we see. Next slide. Of course, given its history and its use and its issues, unmet need has been debated widely for decades. I have included just a few quotes here that span several decades. An economist who questioned the importance of family planning in the 1990s, an NGO, an advocate who wrote papers staunchly against investments in family planning in the 2010s, and a couple of academics who I presume are interested in pushing the family planning field in new directions in the 2020s. I'll take a minute to let you all read through these quotes. I'm not going to read them all aloud, but here is just one. Rebecca Ost of the Center for Family and Human Rights, CFAM, has written, "Unmet need is the product of a multi-decade effort to further the agenda of fertility reduction using selectively interpreted survey findings." And next slide. So as John Casterline and Stephen Sendig, sorry, I misspelled Sendig's name here, wrote 22 years ago in their fantastically informative paper in Population Development Review, Unmet Need for Family Planning in Developing Countries and Implications for Population Policy. That paper has much relevance and resonance still today. As they wrote then, skepticism and criticism of the concept, its validity and its utility as a guide for policy formulation and program design were cogently articulated and gained widespread currency in the 1990s and continues today. Next slide. So perhaps as True Detective character Russ Cole pessimistically says, time is a flat circle. But I'd like to think that we're charting new territory in family planning and that our current interest in rethinking unmet need, that we're really smart and creative. But I also wonder if our cycle of debating, measuring, rethinking unmet need is perpetually on repeat. Are we treading well-worn ground? Next slide. Which brings me to common criticisms of unmet need. Next slide. So, though we are possibly treading well-worn ground, in my opinion, what makes debates about unmet needs so fascinating is that they reflect broader debates in the family planning community and beyond. Here, the longstanding question, what is the role of family planning and fertility change? And perhaps a newer question, but perhaps not, what should the role of family planning be in generating demand for contraception? Next slide. As to the first question, what is the role of family planning and fertility change? We have two camps. Team Distal believes that fertility desires are what drive fertility, not contraceptive access. Team Proximate believes that family planning programming, supply, knowledge, social norms, attitudes, enabling policies, and more are what enable individuals to achieve their pregnancy prevention intentions. I'm curious to know, like, those of you who have strong feelings about this, which team do you identify with? Type it in the chat. Okay, nobody wants to pick a side. Well, I'm Team Proximate. Proximate, a lot of proximates. Okay. Oh, Distal, boom, Linnea, sorry, coming in. Distal, both. Okay, good, I like it. Next slide. So this is the second big question. In my opinion, unmet need frees family planning to some degree from its past, its connection with numeric-based and oftentimes coercive population policies. But at what point does it become coercive to try to convince someone who does not want to become pregnant that they should use contraception? This is another major debate in family planning. To what degree should family planning programs be about generating demand for contraception? And sub-questions include, should ever be about generating demand for a given type of method? Should it be about elevating modern methods above traditional methods? Those who are in the expansive role camp believe that family planning programs must address a variety of demand side barriers. Whereas those who are on the limited role camp believe that family planning programs risk becoming coercive if they expand their focus beyond supply side barriers. I'd love to hear your thoughts on this question too, and like type it in the chat, raise your hand, or this, like the others, I think probably is like serves for really good discussion. So like if you've got a lot of feelings, like hold on to that and let's get into it in a little bit. Okay. Tiffany says somewhere in the middle. Next slide. These debates get hashed out in common critiques of unmet need. Here are 6 common critiques that I'll describe today, but this is not an exhaustive list, and I'll elaborate on each of these critiques and share some rebuttals or some thoughts. Many of these critiques are further explored in John Casterline and Stephen Sindig's paper that I mentioned just a few slides back. Next slide. So turning to critique 1, in his scathing assessment of unmet need published in Population Development Review in 1994, Lant Pritchett put forward multiple criticisms of unmet need, which boiled down to the notion that the concept is just plain old wrong. Criticism A is that unmet need has no basis in individual experience. It's a construct imposed on women by a quantitative researcher far away. B, the concept is illogical. If individuals truly wish to regulate their fertility, they'll find a means to do so. C, the concept is patronizing. It presumes irrational decision-making. D, the concept is backwards. Fertility decline results from changing fertility preferences, not from addressing unmet need. Next slide. And here are these slides get a little text heavy. I'm sorry about that. You can listen, you can read, whichever you prefer. So here are some responses to that line of argument. For criticism A, yes, unmet need is an inference made by the researcher. However, the most direct evidence of unmet need is the high incidence of unintended pregnancy and unwanted birth. As John Casterline has written, quote, women's willingness to report that large numbers of recent births were unwanted or mistimed is difficult to reconcile with the argument that unmet need occurs only in the mind of researchers. And as Sarah Bradley, Trevor Crofts, and Shay Rutstein's research has found, quote, approximately 70% of unwanted or mistimed births arise from non-use or discontinued use of contraceptives among women wishing to avoid pregnancy. In other words, unmet need, with the balance stemming from accidental pregnancy occurring when using a method. For criticism B, it's illogical. This criticism misses the entire body of literature and knowledge of social science and behavioral theory, preferences acting under constraints, which explains that it is logical that preferences to avoid pregnancy are stymied by constraints and obstacles like fear of side effects or experience of side effects or partner opposition and the like. Criticism C, for the same reasons described in criticism B, it does not presume irrational decision-making. And criticism D, it's backwards, the logic is backwards. Yes, the underlying force of fertility change is a change in fertility preferences. However, the linchpin of Pritchett's argument that reducing unintended pregnancies does little to contribute to fertility decline is flawed. Proof of flawed reasoning is in both model-based estimates that John Bongartz has undertaken and empirical estimates, which show that as fertility preferences change, unintended and unwanted births increase, and therefore reductions in births among those most at risk of unwanted birth make a disproportionate contribution to fertility decline. The adoption of contraception by those with unmet need is a major source of fertility reduction. Next slide. So here is critique number 2, that its relevance to programming is minimal. The main thrust of this critique are that the measure has limited real world value because it's never fully attainable, and that most reasons for non-use are not about access to contraceptive methods or services. Next slide. In response to A, yes, true. Many women with unmet need are unlikely to adopt contraception anytime soon because their reason for non-use is due to their perceived lack of risk or their social, cultural, health concerns or the like. The balanced view, though, is that some proportion of unmet need does represent latent demand that is susceptible to conversion into contraceptive use. And this is borne out in evidence. And this also gets into the debate about how much should family planning take a role in driving demand for contraception. With regard to B, unmet need has not been operationalized by family planning programs to first identify women with unmet need and then deliver contraceptive services to them. Moreover, studies from different settings show that improved access can have a profound impact on contraceptive use. And then, as I've mentioned, perhaps more fundamental, family planning programs can have impact on other barriers to use. Limited information and knowledge, social opposition, and health concerns can and have been addressed through successful family planning programs. Next slide. Other critiques focus on why unmet need is an underestimate or an overestimate. And here are just a few examples. Some of these examples are from folks in the room today. In the too narrow side, because it focuses only on women, it neglects the needs of men or couples or unmarried women who are not frequently or recently sexually active. It misses those who are dissatisfied with their current contraceptive. And in the too broad camp, it doesn't account for intention to use contraception, so it inflates the population in need. Or by assuming sexual recency among married or in union women, it also likely inflates potential need. Next slide. Okay, so for the first critique, for men, unmet need has to be ascertained for every partner, which is a challenge. For couples, it's impossible to make sense of divergent partner reports of contraceptive use. Husbands typically are more likely than wives to report use, especially of male methods, and resolving these divergent answers has stymied coupled unmet need calculations, although I'm sure Professor Becker could elaborate much better on that than me. And for unmarried, restricting unmet need measurement to women who recently had sex serves to improve precision of the estimate itself. It's a positive, not a negative. With regard to dissatisfaction with the current method, in my opinion, this seems to be a different but really important concept that is a measure worthy of exploration. And of note, contraceptive discontinuation, which is possibly a reflection of dissatisfaction, contributes substantially to unmet need. Moving on to the not narrow enough critiques, intention to use represents a conceptual shift that reflects the debate on the role of family planning in building demand for contraception. That said, it is a relatively easy fix to disaggregate unmet need by latent demand, with the intention to use, as has been suggested by researchers of late. And as part D, various choices can influence the scope of unmet need estimates. Choice like the spacing timeframe of 2 years has been described as arbitrary but reasonable. Meanwhile, more complex issues concern classification of women who were not at risk of pregnancy because they were already pregnant, or they were in a state of lactational amenorrhea, they were sexually inactive, or they were infecund. And Sarah Bradley and John Casterline explored some of these sensitivity pieces and found that generally the issues operate in different directions, with some inflating and some deflating unmet need, with the end result being the inflation and deflation offsetting one another. Next slide. Critique 4 is that it's a Trojan horse. So here the criticism is that the focus on unmet need maintains the focus on contraception to the neglect of other interventions, where the focus on unmet need keeps the world from using limited resources on more pressing and real concern. The Trojan horse factors in here because these arguments suggest that unmet need is a status quo population policy dolled up as something different. Next slide. So in response, I would echo John Casterline and saying that there is nothing about unmet need for family planning as a concept that requires family planning to be higher or lower priority than any other reproductive health area. Family planning and the broader reproductive health agendas are not at odds with one another. I'd also say that unmet need is a real concern. It results in unintended pregnancies and births, which have negative repercussions for health, wealth, empowerment, education, and more. And finally, unmet need is not dolled up fertility control. It's an imperfect measure of population level phenomena, the apparent disconnect between the need to prevent pregnancy and then the non-use of contraception. Next slide.
Actually, Madeleine, maybe before we go on, there's two comments in the comment chat that sort of directly related to what you just said in the last two slides. One from Stan asking about whether you could consider the measurement of unmet need for men for condoms or vasectomy. And then another question from Caroline about how they can assess that, you know, mismeasurement balances itself out. I don't know if either of them want to elaborate on those comments. No, maybe not. Just if you have any comment in response to either of those.
Yeah, I mean, I think, yes, looking at male-specific method use would be interesting to explore. And then thinking about, yes, their desire to use contraception and their desire to use a given contraceptive method, which could fit into unmet need or maybe is a different type of a measure. And how can they assess that mismeasurement balances itself? I think, so I'd have to go back to the paper from 2014, Caroline, but I think that what they did was that they just tested a number of different assumptions. And let me not opine on that. I'll send you the link and then we can talk after we both reread the paper. Does that sound okay?
Sure.
Thanks.
Thanks.
Okay. Next slide. All right, the fifth critique is that it's anti-feminist. And this is the most recent characterization of the concept, as Lee Senderowitz and Nicole Maloney recently wrote, quote, attributing an unmet need to women who have access to contraception but choose not to use it serves the interests of neither the women themselves nor any rights-based programs that seek to serve them. Next slide. In response, I'd reflect that the counterfactual seems to me to be that a woman would choose unintended or unwanted pregnancy rather than contraception, including in contexts where abortion is illegal. Given the myriad contraception options, including traditional methods, the idea that family planning programs would consider these women's needs met is dubious and a debate worth having. Feminism can take many forms. Next slide. The sixth and final critique I'll talk about is that unmet need is widely misinterpreted. As written in peer-reviewed journals earlier this year, quote, it ascribes a need to a woman that she may not ascribe to herself. And its meaning is often misconstrued because the labeling is often confusing. Next slide. Here, I'd say that unmet need is intended to be used as a population level measure, not an individual one. It is not used in service delivery and is not ascribed to any given individual. And to me, this is a great example of how the measure is misinterpreted. In their paper, Eileen Spicer and colleagues suggest one easy fix, which is to rename unmet need, perhaps, quote, % of women who want to avoid pregnancy but are not using contraception, end quote. I think this is a great suggestion, but if we adopted this, even if we adopted this suggestion, widespread misuse and misinterpretation of unmet need will likely persist. Next slide. So in response to criticisms of unmet need and the push for the family planning field to continue to evolve, Spicer, Bremner, and Farid recently suggested, quote, both existing and new measures must be examined and perhaps reframed to ensure that perspectives of users, potential users, and non-users are included. Without this effort, we risk programs and policies emphasizing measurable, i.e. status quo, outcomes such as unmet need and demand satisfied, and never moving into the realm of what else should be measured to better direct efforts that meet women's and girls', men's, or couples' self-defined contraceptive needs. Next slide. So these reflections on unmet need reminded me of one of my favorite Al Franken characters, self-help guru Stuart Smalley. In looking in the mirror, providing affirmations of the use and usefulness of the unmet need indicator, it's also important to recognize that we can and always should be striving for improvement. Next slide. And that brings us to the third and final part of today's webinar, new measurement directions. Next slide. So many researchers, many sitting here in the PopFam department, the PMA project, the Gates Institute, have made suggestions for improving unmet need estimates. And here are just a few of them. On the left side, you'll see suggestions related to inclusion and exclusion criteria. First is we should continue testing the sensitivity of unmet need estimates to various assumptions. So the paper I was just mentioning, Caroline, Bradley and Casterline, found that unmet need was highly sensitive to the choice of the duration of postpartum amenorrhea of 24 months, which is currently used, versus 6 months, which is standard clinical advice. If we went with the 6 months, you would see an unmet need increase by, on average, 3.4 percentage points. We should also continue exploring the role of ambivalent fertility intentions and pregnancy acceptability. And we should continue exploring the role of sexual frequency and recency. As Suzanne Bell, who's here, and David Bashai found in their 2017 analysis, women may be consciously regulating the frequency of sex as a means of family planning. We should also consider how we tabulate and disaggregate unmet need. There's been research of late suggesting that unmet need be disaggregated by latent demand, or that it be disaggregated by supply side and demand side unmet need. And then on the right side, more precise contraceptive prevalence estimates will also make more precise unmet need estimates. So contraceptive prevalence is currently calculated based on a question of current use. And this current use framing may underestimate contraceptive use among individuals who are not having frequent sex or recent sex, and individuals who use coital dependent methods. We should consider retabulating contraceptive prevalence to include use at last sex. Current use questions may also undercount permanent methods like sterilization, as well as coital dependent methods and traditional methods. So recognizing this gap, DHS recently added new questions to directly ask about sterilization, coital dependent method use, and EC use. And the answers to those questions should be examined with the consideration of, again, retabulating contraceptive prevalence. And finally, research is accumulating that shows that women are using postpartum abstinence and prolonged abstinence as a method of family planning. So for example, a qualitative follow-up study to the 2014 Ghana DHS found that 18% of respondents reported abstinence or infrequent sex to avoid pregnancy. And these were women who had previously been categorized as having unmet need. So the family planning field should work to make a determination about how to capture abstinence and account for it in key measures. If unmet need and contraceptive prevalence estimates took sexual recency into account, perhaps this issue of abstinence could be solved. Next slide. Another alternative recently suggested is the Tekponan Chikwago approach, which uses 7 questions seen here in the upper left to understand a woman's own assessment of her pregnancy risk. The underlying assumption is that women's perceptions of their need are more likely to guide their choices than any sort of a physiological need. So using responses to these 7 questions, the researchers explored actual and perceived needs, which are defined in the bottom right box. And they found that, quote, perceived no need, women who believed that they could not become pregnant despite the fact that they were fecund and sexually active, was quite high in both study countries, end quote. And they posit that this approach is more helpful than standard unmet need calculation for designing programs to better address women's and men's individual needs and diverse contexts. Next slide. So this brings me to my own recommendations, which I wrote about in a commentary that was published just a few months ago. Next slide. So if we want to move our field forward, I think that we should first establish or reestablish shared meaning and shared definitions. Second, recognize, measure, and understand 4 types of interrelated yet distinct family planning needs and demands. And third, address known measurement issues, many of which I described in the preceding slides. Next slide. Okay, so for recommendation 1, I think it's fascinating that much of the jargon that family planning uses stems from the economics field. And in that vein, I think it's important to define what desires, wants, needs, and demands are. This part gets a little bit weedy. Maybe this whole presentation is a little weedy, but the gist of it is that wants and needs are types of desires. The only difference is that a need is something essential, whereas a want is non-essential. In my opinion, an individual's intention to prevent pregnancy is a need. It's essential. Something becomes a demand when ability and willingness to act are added into the mix. I also think it's important to define family planning. We often use family planning and contraception interchangeably, but they're not the same. Family planning is larger than contraception. It's the services, policies, information, attitudes, practices, and commodities, including contraceptives, that give individuals who desire to avoid pregnancy the ability to do so. I used to say that family planning helped individuals and couples achieve their fertility intentions. But I think that the reality is that family planning is still very focused on pregnancy prevention. And as a result, I've modified my definition over the years. That said, and as I've written in this piece and in this note here, ideally family planning is more broadly focused on helping individuals achieve their fertility intentions, which includes not only pregnancy prevention, but also pregnancy planning, infertility counseling, sexual and reproductive health education, body literacy, and more. And we're often talking about family planning in the context of reproductive justice. And for me, that's not just about person-centered measures or person-centered care. It's about the scope of our work, including our work to support people to parent the children they have, which means strengthen linkages with other sectors. Next slide. My second recommendation is that we need to tease apart the different types of family planning related desires and demands. And as I see it, there are 4 types: the desire demand for reproductive autonomy, to limit or delay pregnancy, to use contraception, and to use a given contraceptive method. Next slide. So to elaborate and back to definitions, reproductive autonomy is having the power to decide and control contraceptive use, pregnancy, and childbearing. People with reproductive autonomy can control whether and when to become pregnant, whether and when to use contraception, which method to use, and whether and when to continue a pregnancy. Uniquely, reproductive autonomy encompasses all other types of family planning related demands. The desire to or demand to limit pregnancy is based on the individual state of preference. The desire and demand for contraception is based on an individual's desire demand to use a method or a device that prevents pregnancy, and the desire demand for a specific contraceptive method is just that method choice. Next slide. When it comes, next slide. Thanks. When it comes to measuring these different types of demands, we need a new set of questions and corresponding indicators. What I shared in this table is not reflective of how actual survey questions should be formed, but it's illustrative of what types of questions we'd need to ask. For example, does the individual believe it's within their power to prevent pregnancy? To what degree would the individual judge pregnancy as acceptable or unacceptable? Does the individual express the desire to use contraception? Is the individual using their preferred method of contraception? These types of questions can bring us to a more person-centered, holistic understanding of family planning needs and demands, and the degree to which they are satisfied or unsatisfied, met or unmet. They can also bring us other key information heretofore missing, like an individual's desire to discontinue contraceptive use. Next slide. And when it comes to addressing known measurement issues, I agree with Spicer and team's suggestion that we rename unmet need to reduce misunderstanding and misuse. And I agree that we can and should continue to improve the measure of unmet need through revisiting the inclusion-exclusion criteria, improving its tabulation and disaggregation, improving the precision of contraceptive use estimates, and more. Ultimately, I hope that we stop assuming that we can have only 1 or 2 or 3 family planning indicators. This conversation doesn't need to be about replacing unmet need. We can take a yes and approach. Next slide. I'm getting to the end. I do, though, want to take a couple of minutes to share a new avenue of thought that Professor Amy Choi and I have been tossing around of late, and it's about contraceptive hesitancy. What you see in this figure is that vaccine hesitancy programming and research has provided a spectrum of vaccine outcomes. What if contraceptive programming research took a similar approach? The spectrum would be wide, spanning individuals who will refuse all contraceptives no matter what, to those who will adopt any method in order to avoid unwanted pregnancy. And in between those two endpoints, there'd be many types of users and non-users, including individuals who are hesitant to begin using a contraceptive method after the birth of a child, after a miscarriage or abortion, or after another life event. Those would be those who refuse but are unsure. They're unsure whether potential contraceptive side effects outweigh the risks of unintended pregnancy. They're undecided. And they use contraception, but they're dissatisfied with their method or hesitant to switch to another. They accept, but they're unsure. To develop the necessary contraceptive hesitancy measures, the field could embrace questions that include psychosocial scales. To begin, we could transform the contraceptive intention question that's long been used in DHS and other surveys. Quote, do you think you will use a contraceptive method to delay or avoid pregnancy at any time in the future? Yes, no, unsure, into a scale that is like no, probably no, undecided, yes, etc. Such a change could help elucidate the spectrum of contraceptive intent. Next slide. Second, the field could build from the vaccination community's 5C scale for measuring vaccine hesitancy. This is confidence, constraints, complacency, calculation, and collective responsibility. Based on social and individual dimensions of vaccine hesitancy, the scale provides a validated short set of questions to monitor hesitancy and includes all aspects of vaccine hesitancy available in the literature. This type of measurement, building from the work of the immunization field, could help us to better understand and respond to individuals' demand, non-use, and use concerns and trepidations. Of course, it all needs testing, nudge, nudge. Next. Okay, almost to the end of this presentation, and I do want to note, through all the discussions and debates, it's important to remember that family planning is socially, culturally, and politically fraught. And ongoing attacks against family planning, including the need for family planning and the scope of the problem that family planning aims to address, make it a challenge for those of us in the field to be reflective, proactive, and open to change. And it makes conversations about unmet need all the more challenging. But that doesn't mean that we shouldn't be having them, and I'm glad that we are. Next slide. So I started off this presentation with a list of 4 goals, and as a reminder, here they are again. I hope that I've been successful in achieving them, at least to some degree. Next slide. And I wanted to, before giving all my thanks, give a special thanks to Dr. Apurva Jadhav, who partnered with me on an unmet need presentation we made to USAID colleagues a few years back. Much of that presentation informed this one. And I wanted to thank so many folks working on unmet need now and in the past. This is an incomplete list, but I felt obliged to give a few nods, as it's a mighty intellectual force that's been reflecting on and rethinking unmet need for a long, long time. Next slide. Thank you again for having me. Let's have a discussion.
Thank you so much, Madeleine. That was great. I think maybe while people are formulating their thoughts and questions. Maybe we can go back to something that we touched on earlier in the presentation, Stan's question, which also I think was tangentially related to a point of Caroline's that I missed about unmet need not being a point prevalence, and then Stan's comment about the sort of women's ability to answer or changing in time, and which are most problematic. I know you said you wanted to kind of come back to that, so maybe we can start with that while other folks are thinking about their comments and questions.
I mean, I think Caroline has done great research on what an actual point prevalence estimate would look like. And I think what we could see from back in that flowchart diagram that I showed you is that because unmet need estimates infer unmet need among women who are pregnant or in the postpartum period, if their pregnancy or their most recent birth was mistimed or unwanted, it means that it's not a given point in time, because it's got this retrospective piece connected with it, which is yet another very confusing element of unmet need, and one that has been debated for a long time. And I see that Caroline has her hand raised, so please chime in.
First, well, thank you so much for that presentation. I agree with all of what you said. This was great. I just wanted to kind of reflect on the fact that, to me, a lot of the tension is that we have a demographic measure. As you said, it's a population-based measure. And so that it's not a point prevalence, and it doesn't reflect the need of an individual. And even if without talking about the individual's actual intentions of using contraception, even it doesn't reflect the individual risk of pregnancy either. And so that's really a point of tension to me, because more and more this measure is used to understand the cause and consequences of unmet need, but we don't have an individual measure. And it's ecological fallacy almost to use a population-based measure that doesn't reflect individual risk and then try to tie it to individual characteristics or health consequences, both perinatal and maternal. And I think that's a huge tension in the field. I think we're still stuck or using that population-based measure because we want to think about trends and monitoring, and that's important. But as we move towards kind of understanding causes and consequences, we're just stuck in some ways because we don't have an individual level measure. And that's where your presentation fits in, about how to best describe that individual level measure. And there are multiple complexities about how do we measure risk of pregnancy, and how do we measure intention in women's desires and preferences with respect to contraception. So I don't have any responses, but I see that tension in that conversation.
Thank you so much for that feedback and reflection, which you synthesized so well what so much of the tension is. I'm glad that we recorded this so I could go back and crib some of what you said. Ishrat, I see you've got your hand raised.
Yeah, I completely agree with what was just said, because it's really the individual, and the population-based measurement really do not reflect that. For example, I can imagine that women are not using contraception because they don't have any idea whether they can limit their family size or cannot limit their family size. They don't have adequate information about the choices in contraception. So there are a host of factors at the individual level that affect demand, and therefore this type of aggregate measurement may not be very useful for the policy making.
Thanks, Ishrat. Lynn?
Yeah, sorry, I was just unmuting. When you talked earlier about like the rights-based arguments, something that came to mind is like a lot of family planning rights have been sort of reframed into broader terms as sexual reproductive health rights. But if we try to like disentangle unmet need for family planning from unmet need for contraception, the definition would also have to change, because contraceptives can be needed or demanded for other reasons besides family planning or pregnancy prevention, right? Because, you know, I remember like as a younger teenager, before I was, you know, sexually active and had a need for it, I was on birth control for other things like painful periods or, you know, excessive bleeding and things like that. And I think like I've heard other reasons for friends who are also not sexually active using contraception for other health reasons. And so I think that if we're trying to make this about sexual reproductive health rights, we will have to take a broader look aside from, you know, pregnancy prevention.
Yes, I agree. And I talk about that a little bit in the commentary about how if you were looking at contraceptive use, that there's a lot of contraceptive use that is not connected, like you were saying, to pregnancy prevention, but people are using contraception to, you know, reduce the severity of menstrual cramping or bleeding or acne or, you know, a whole host of other reasons. And I think that if we did start to disentangle that, we would start to get maybe a more nuanced and fuller perspective of that broader SRHR piece that you were doing, I think, Lynn. And it sounds like from Ishrat's comments as well that, you know, we all agree that we need individual level measures. And I think there's it's really hard. I mean, I feel like where you get that right is, you know, some of the just one question kind of work that came out of the United States about, you know, when women or individuals go to have yearly checkups, the doctor should, or the nurse practitioner should ask, do you plan to become pregnant in the next 12 months? And then have a conversation about that answer. I think where we keep getting like a little bit stymied is that we want these individual level measures that we can, like, out of these big surveys. And I think there's so much that creates a whole host of sort of implementation challenges, including like how do you frame, not only how do you frame the question, but is it right for the population that you're asking it to? And it requires, I think, a lot more thought work, but I hope that at least having a framework for what the types of family planning needs and demands are, like I shared in the commentary, can at least help guide the direction that that type of exploratory research takes, and ultimately potentially adoption in our large survey programs and in other like large data gathering sources. Caroline?
Yeah, and another thing that I was thinking as you were presenting is, even if we take on the population level approach and not only the individual, I think one of the concerns is it doesn't match clinical recommendations. And that's relevant for family planning programs. So for instance, we do not wait for 2 years to prescribe contraception after a woman delivers. The clinical recommendations, including WHO, is that contraception be prescribed immediately after delivery. So there's kind of a mismatch in some ways between the definition, even if it's used at the program level and at the population level, with the current clinical guidelines. So that's maybe something, at least for the population level measure, to be addressed.
Stan, and yeah, I think that's a great flag also. And one, like I mentioned, with the postpartum period, whether it's 6 months, whether it's like immediately postpartum or the like, that you know, how much do you want to tie the measure to what clinical guidance is, and then what is that? It's a good question. Stan?
Wait a minute. Coming. Oops, can't get my video, sorry. Yeah, thank you. Oh, there it is. Oh, very nice. So back to Carolyn's comment that it's a population level and not individual level measure, which is very nice. That would seem to me to say it's okay to incorporate husbands or men. Also heard thing about the clinical, yeah. So if it's population level, one can distinguish women in couples where she wants no more births, but he does, from women in couples where both of them want no more births. Otherwise, we're so individualistic. We're only talking about a woman and the women are in relationships, and it seems that somehow we ought to take that into account. And yeah, so I guess that's my comment. If it's population level, then we can expand without worrying too much that we're not dealing with individual women. Thank you.
I'm all for couples unmet need. And talking to the unit when a unit exists. What I think it was Sarah Harbison, I think, had written one of the critiques that I shared, which was that it's less about the divergent fertility intentions in the couple, and it's actually more about discrepant reports of contraceptive use. So when you start with like the couple at the top of that decision tree, and the very first piece is using or not using contraception, and you have the husband who's saying that they are, and the wife who's saying that they aren't, there's no place to, you can't follow the decision tree for that.
But my understanding is the latest DHS last 10 years or so have shown that women's reports are higher than men's reports. That was not true 20 years ago or so, but hasn't it switched? Thank you.
I trust you. If you're saying that it's switched, then yeah, it must have switched.
Our Gates people can check. Thank you.
Amy?
Hi, you may hear some background noise that will sound like a 2-year-old, but in any event, I'll ask quickly. I don't understand this distinction or this critique of unmet need as being a population level measure. I mean, sorry, you heard it. When you calculate unmet need, you have to calculate it for individual women, and then we aggregate it at the population or subgroup level. But when we're applying it, we're applying it against demographic outcomes, whether it's fertility or mortality. But it is an individual level measure. I think what we should be thinking about is how you use patient records or family planning client information to assess unmet need, or to assess the need of that individual, that client, in terms of their contraceptive need or their overall family planning need. I agree with Stan's comment that it includes abortion. So anyway, I just wanted to say I don't think it's a population level measure unless we're relating it to population outcomes. It's really measured individually, and maybe we don't agree with how the components, the 15 questions that go into it, but that doesn't mean it's not an individual measure.
I think that's okay. So since it's not based on direct questions that you're asking to an individual though, right? I mean, it's a combination of inferences and calculation to arrive at that juncture, which
well, we do assess her fecundity status. We assess her fertility preferences, we assess our current use. We do this all for an individual respondent in the survey. And then when we tally it up, we get this unmet need measure. So we could go around saying this particular respondent, you know, has an unmet need because she answered A, B, C, D of those 15 questions. But my other point really is that we shouldn't rely on household surveys. I mean, if the intention is to deliver services to those who are interested in them, we should be also doing a better job with building this into family planning, client record systems, and health information systems.
I fully agree with your second point. I'm not sure that I agree with your first point, although I hear you that the information is collected at the individual level. Stan?
Yeah, I just say, in answer to Amy, I mean, Carolyn's right in the sense that if she didn't want the last birth, but she's in postpartum amenorrhea, she doesn't have unmet need now. She had unmet need maybe 6 months ago or something, or 12 months ago. So I think that's the problem with taking it as an individual level.
Right, but
over time.
That's more to me, that's more an issue of the temporal measurement, not so much the level or the unit of analysis.
But that woman doesn't have need now. Oh, I see. You accept that she had need before. Yeah, maybe. Madeleine?
Well, I mean, I think it's also the challenge of applying it then at the individual level is that, you know, in Ghana and Nepal, DHS did some follow-on surveys of women who had participated in the household survey, and these were follow-on qualitative interviews. And what we saw is that unmet need status was very fluid. So revisiting a woman maybe just 3 weeks later who had said that she didn't want to have a child in the next 2 years, in the qualitative interviews, you know, it's more nuanced, and she's saying actually it wouldn't be a problem, and or they're learning that, you know, actually she had been using abstinence for family planning and she didn't actually have a need. So there's measurement issues, but then I think there's a challenge that much of this is not static. And if you were to apply it at any given juncture to an individual, I think you could very easily get it wrong, which is why I think it becomes really important to think about what is this, like, not applying it at the individual level and keeping it at the population level for its connection, like you were saying, Amy, to other demographic outputs, but also as an indicator of potential programmatic need, the scope of the problem of people who report that they do not want to become pregnant, but are not, you know, but are at risk of unintended pregnancy. Over. I see. Okay. Amy, is your hand still up? Do you want to say something else?
Oh, I didn't know I should take it down. Just very quickly, I would just say, yes, the validity of unmet need may not be very good for the individual woman because it is fluid. It will change. But I just was trying to draw a distinction. It is an individual level measure because it's measured for individual women. So we probably have to think of another terminology.
Okay. Yeah, I agree. I understand now, and I agree. Carolyn?
Yeah, I just want to make a comment about, fertility preferences, need for contraception, etc., change over time. But this is a point prevalence. Contraceptive use, it's a point prevalence. It's a snapshot. It might change tomorrow, or it was different yesterday, but that's true for the whole population. So if you want a snapshot, it's a snapshot now. And so that, to me, that's the real problem of the demographic methods. It's accumulative, but it's not accumulative for everyone on the same time frame. So for women who were pregnant and postpartum, the time frame goes 2 years back. And for others who are not pregnant, the time frame is right now, and we accumulate that as a aggregate measure. And it's kind of puzzling to me that we don't have the same reflection for contraceptive prevalence or other indicators that is just a snapshot, recognizing that those behaviors change over time. And if we do the survey again 1 month from now, that women will maybe change status. But I think we have to disaggregate the dynamics from the snapshot. And that's why we need longitudinal data.
Yes, I agree with you. And I've actually had I have had this debate in the contraceptive prevalence space when I've talked about limiting contraceptive prevalence to women who report recent sex. Because people say, well, there are a lot of women who would still be at risk who don't report recent sex, but presumably in that cross-sectional point prevalence, you'd be capturing the women who don't regularly have sex but happen to have had it during that month. So I agree with you, and I think the challenge, why would we, in places where there's a lot of unwanted fertility, you would presumably have high unmet need. And I guess what we need to do is just remove all of those women from I think there is a conceptual reason why you would want to include women who recently gave birth or recently became, or are pregnant, and they did not want that birth or the pregnancy was mistimed, because those women presumably represent a population that's at increased risk of that exact outcome. So if you removed them from unmet need, how would you capture them elsewhere? Or what does that look like for the unmet need estimate? I think the 2012 revision looked into these pieces a little bit.
To me, you're double counting women. These women had an unmet need 2 years ago. Had you done the cross-sectional 2 years ago, they would fit in the unmet need, and now they're pregnant. Women who fit right now in the unmet need category at a particular time point might get pregnant 6 months from now. But if you're double counting them in some ways, because you're accumulating their time of unmet need at different time points, I just think that they perhaps are double counted.
I hear you. And I guess it'd be really good to look at the dynamics to know whether the women who are currently not pregnant and not in the postpartum period are representative, are representative or represented in the population of women who are neither of those.
And I think
anyway, I know that
just to kind of conclude on that, I think a useful measure could be with the calendar, and I don't think we measure it right, but the accumulation of unmet need on the course of a certain period of time, 1 year or 2 years, but counted the same way for all women, not only pregnant or non-pregnant, I think would be really useful, because women shift in their status, and we would have accumulation of unmet need for everyone consistently over the same time frame.
I love that idea. I know that we're past time.
Yeah, I was just going to jump in and say there's a fascinating discussion, and I love that we're actually moving towards ideas of actual new and additional measurements, going back to your point of the idea that perhaps we were asking too much of a single measurement to capture the entire state of family planning need. But it is time to close. Thank you so much for this presentation. Obviously, we've got lively and engaged audience and a timely and important topic. So, and thank you all for joining.